Katul Patel. I'm the CEO of Virginia Mason Francis Canelton. I'm sure we'll talk a little bit about some of the challenges that we've had at our health system over the next hour. But I just want to comment on one thing that I heard this afternoon from Leah in terms of her presentation. All of us, are looking at data and information every single minute and in our management lives. But what we don't see always are faces. And what Leah presented to us were faces of patients that actually we could control in terms of their extension of their lives. And I think that has really deeply impacted me spending time this afternoon. Do I think there's a state of urgency? Absolutely. And I think it's becoming a lot more open in terms of discussion that's going on around the country. So I think that's wonderful to hear.
Hi there. Can you hear me? Okay. We're just going to use the microphone. I'm Beth Russell. I'm the director of Knoxville Orthopedic Surgery Center. We're an orthopedic-only surgery center in Tennessee. Proud to be here to represent the ASC community. Obviously, over the last few years, we've seen lots of surgeries migrate to outpatient surgery center, and I'm excited to be involved with Leapfrog and helping prove how safe surgery centers can be. For sure, I do agree that there are issues with patient safety, and I think it starts at the top with leadership and transparency so the staff feel comfortable talking to their leadership about there's any issues that there are.
Let me see if my mic works. Is it working?
It is.
It is. All right. So hello, I'm Rumay Alexander. I am a nurse. I am a professor at the University of North Carolina, Chapel Hill, and formerly the Associate Vice Chancellor for Diversity and Inclusion for the university. I am also the ANA Scholar in Residence that is dealing with the National Commission addressing racism in nursing. And more importantly, I am a Leapfrog board member. So they get to hear me all the time. Now you get to hear it. There is indeed an urgency. And I think, to be very brief, is the stories and the faces that you saw are all about what each of you two are about, and that is we're all in the experience business. And we need to pay attention to the experiences of those that we care for and make sure that they don't leave those experiences feeling insignificant, forgotten, invisible. Nurses are the surveillance systems in our institutions. And when you don't have enough nurses, you're not in a safe space. It's just the fact of the matter, because they're there more than anyone else, 24/7. And so you'll hear more about the fact that not only are we on a nursing shortage, but when we are in one, how stretched it is. And when the ratios of nurses to patient care are compromised in the name of payment or cover-ups or other pieces, then you get these tragic stories that we just heard in the space. And while we're all human, and we make mistakes, when we're stressed out, we make more mistakes. So you'll hear more about that as we talk.
All right, is this working? Yes, no? All right, we have a backup plan. That's resiliency, right? So I'm Michelle Schreiber. I'm a primary care physician by background. Most of my career in the city of Detroit as a primary care doc. Have been involved in quality and safety in large systems for many, many years before going to CMS, which was about 4 years ago. I'm the Deputy Director of the Center for Clinical Standards and Quality at CMS, and those transparent reporting systems, the quality measures, the value-based programs all fall actually under me. There is absolutely urgency. But I've thought that, frankly, for 20 years, which I know many of you share, and have never in my entire career understood why there wasn't and hasn't been more urgency to this. But during the pandemic, and I watched data from across the country, our safety metrics plummeted. Healthcare-acquired infections went up by over 40%. Falls went up. Pressure ulcers went up. Patient satisfaction plummeted. Mortality went up for obviously many reasons. And there are lots of causes of this, you know, the stress of the pandemic, the stress of workforce. But the reality is our systems collapsed for safety. We can't have that in healthcare. You know, you mentioned going to Detroit, which I was really interested in because, you know, I learned a lot of lessons in Detroit, including from the auto companies, where a number of years ago, the auto companies went bankrupt because in other countries, cars, frankly, performed better. And they had to learn their lessons of how they engineered quality and safety. And I've actually had the privilege of sitting in on many of their global safety meetings. So it's real interesting, you know, we think of hospitals and their safety meetings and how big they are, but I would be sitting there in the headquarters of one of the big 4 car companies, and they'd go, North America, South America, China, you know, we're talking global, and they engineered safety. They all had the same metrics. They all had the same analytics. You could walk in a plant anywhere on the globe and look at their safety performance. There was team training. There was communication expectations. And other industries have done this. It's not just the cars that learn that, but aviation, nuclear power, other engineering and manufacturing. The military actually does a wonderful job of this. And healthcare has many lessons to learn from those industries. And I hope that the time is finally right to continue promoting this. I have one last thing to say. I want you to know a nurse saved my life in the hospital once for May. So I'll tell you about that story once. But nurses are really the front lines and the backbone to this, so thank you.
Can you hear me? Yes, you can. Okay, good. I'm Marty Hatley. I'm a lawyer. I've been on the Leapfrog group board for 12 years. I just transitioned off. I termed out, so I'm grieving a little bit at this meeting. It's my first time here, but still a part of the community, obviously. And for the last 23 years, I've been encouraging patients and patient groups to partner with the healthcare system to improve safety. And we've done that. I kind of went into the Nader groups and the People's Medical Society right at the turn of the century and said, look, don't fight it, you know, partner. The healthcare system is serious. There's a call to action. And that was 23 years ago. So you used the word, Leah, disillusioned. Is that the word you used? I'm sorry. Demoralized. So patients are demoralized, but they're also skeptical. They're cynical. They're untrusting. And when something like Vanderbilt hits the newspapers, and you know, one of our leading organizations, you know, has that level of intentional cover-up, it just sends a signal that not only goes to nurses, that's demoralizing, but to patients and families. And I don't want to just pick on Vanderbilt, because every 2 years or so, there's a big blockbuster story in the New York Times about some healthcare system that's covered something up. Knew about problems, didn't want to go public with it because it was going to be bad for, as Leah mentioned, bad for their reputation, or there's a powerful, you know, block within the organization that blocks it. It's sometimes easier to go to a reporter than it is to take on your own administration, which is disillusioning to me. So patients and families, 2 years ago, there was a major report put out by the World Health Organization on patient safety, because they looked worldwide, just like we're looking here, at the lack of sustainable progress in patient safety over the last 20 years. And they put together a new global patient safety action plan, and it's all about transparency, and it's all about strengthening systems, but it's also calling upon governments to coordinate better and really keep the serial killers from moving from jurisdiction to jurisdiction. I mean, we are in a situation here where I think, with all due respect to Michelle Schreiber, who is one of my favorite people ever, because she's such a leader at CMS, but there are agencies within the federal government that just really don't talk to each other about safety. They all have a part of the safety mission, but they're not coordinated enough. They're not coordinated with the states between licensing boards and departments of health and departments of nursing and all of those different places. There's just not the kind of coordination where we've come to expect, or we thought we would get from our leaders. So there is, I think, a need for urgency, and I think it's an old need. I don't think it's gotten better. It's like racism, embedded racism. It's just been kicked down the road for too long. We've had data about disparities in healthcare for at least 25 years that I've been caring about it, and we still have this problem. So patients now, I'm working on a framework with WHO about sort of reinventing patient and family engagement. So far we've been really stressing, partner with your providers at the point of care, make sure your loved one or yourself gets safe care. Move into the hospital when, when your loved one is there to just kind of watch what can fall between the cracks. We've also stressed really partner on improvement work. Join a patient and family advisory council, get involved in some way with your organization. But we're seeing now a need for us to be more activists, to actually speak outside of the partnership arena and put some pressure on our partners to do more and to fulfill their expectations to us, because it just hasn't happened. And we're finding that we can actually say things that sometimes people in positions of power can't say. So, for example, we saw the investigation at Vanderbilt, and we saw what happened. We saw the reaction. No action taken against Vanderbilt by the Tennessee Department of Health. Insufficient responses elsewhere. So we filed a grievance with the Office of Inspector General to look into this further. That's the sort of thing that I think we need to be doing to kind of keep our attention on this. And I know I'm going over my 5 minutes, but I'll be quiet later. One of the things that puzzles me, the transparency issue that Leah put up there, I totally agree with that, Leah. But one of the things you didn't say that I thought you were going to say is just giving a nod to the Affordable Care Act and the importance that put on transparency. And it created new reporting programs. If any of you are involved in the candor work, the sort of open and honest disclosure, that was funded by the Affordable Care Act. There was a lot of research about these kinds of problems that we're dealing with here today. Barack Obama's tort reform proposal was, let's make healthcare safer. There'll be less litigation if there's less injury. That was his tort reform platform. So we had real leadership, and many of the hospitals here, many of you, I'm sure, were engaged in the Partnership for Patients, which was an engine that drove the early elective delivery work and drove it out throughout the system. So we need that kind of leadership again. We have a president who gets health care. So I'm hoping that he will, once he gets through all the other things that he's got to deal with, will realize that this is a national priority. This is the third largest cause of death. And we still aren't counting that, we're estimating it. And that's a problem too, because no one really, it's easier to dismiss the estimates than if we had real numbers about the number of people that we're killing, not just in hospitals, but in nursing homes, and all of the misdiagnoses that are happening in this country. So that's why I think this is urgent, and I apologize to my fellow panelists for taking more than 5, but I'll be quieter later.
It's working. Oh, look, it's working.
Yeah.
So, no, I think those were important statements. And I will say, when I mentioned earlier about transparency and what kicked that off was CMS publicly reporting, I should have said that was because of the Affordable Care Act. That's why we had this new generation, really, of change in healthcare. So, absolutely. So let me ask you a question. When I was speaking, I was talking about this issue of systems. Can we change systems? Well, systems are people too, right? So how do we change a system? Who can change a system? Can you talk to me about what your thinking is about, first of all, do you agree that systems are part of this problem? But assuming you do, what do we do about that? What has to happen? I'm going to turn to you, Katul, first, because I think the Virginia Mason story is very much about a system complete change that resulted in.
Yeah, so let me just actually comment on a couple of things. And for all of you that don't know the history around our system, we came through a pretty significant merger in the state of Washington that occurred in January of 2021. There was a historical Franciscan system that was Tacoma-based, which I was the CEO for, and Virginia Mason Health System, with many of you know that Gary Kaplan, who has been very prolific in his career around quality and safety, and somebody that's a very good friend of mine. The two organizations came together, and I came to the Franciscan system in 2015, just to give all of you a little context. And I've worked at some pretty amazing places in my career, UPMC Hackensack, whose brand around quality and safety is in the top decile, if you will, of healthcare. But I came to the Franciscan system that was prolific in so many different areas, particularly geographic presence, financial performance. I would say, being in the world that I lived in historically in my career, we were above average, if you will, in terms of outcomes. And my first 6 months, one of my first priorities was to make sure that we had a strategic plan in place that was going to be focused on quality, safety, patient experience. And I will tell you, the market did me a favor. Leapfrog did me a favor. And I know Leah knows the story, is that on the front fold of the Tacoma News Tribune, there was a published article on the grades of Leapfrog. And we had 1B, a bunch of C's, 1D, and 1F at all of our hospitals. It was, in many ways, a crying call for us. And you asked a question about systems, and it's absolutely vital to who we are. Before we merged, the leadership team, the board, had a very specific expectations. And we've got a great leader in the audience, Data Khan, who's now our Vice President of Quality. But I will tell you that I look at every single one of our leaders in the organization as the Chief Quality Officer, the Chief Patient Safety Officer. I am the Chief Quality Officer, Chief Patient Safety Officer. And it does start with systems and leadership. To that end, one of the reasons that I fought so hard to make sure this merger happened, because I believed in what Virginia Mason Medical Center has done now for decades. We have something that we call the Virginia Mason Production System, and there's so many articles that have been written about it. You talk about the automotive industry and the reflections that we've had as part of scaling the Virginia Mason Production System. But what I find the most important thing about the production system is it captivates every person in the organization to change the culture, to focusing on making sure there's zero defects. Everybody can stop the line in terms of patient care that what needs to happen. That's the beauty about what we've done. And we've actually now expanded the production system all throughout our new health system. And every leader is going through some level of certification right now. It's an expectation I have. It's an expectation the board have. And I will tell you, as we sit here today, we're the only system in the state that has all A's and 1B. And I keep saying that the B is a B+, because we're going to get to an A. Dana's promised me that her and I are going to partner together to make sure every leader in this organization feels very compelled to say that. Because I say this over, grades are grades. Whether you believe in these grades or not, it doesn't matter. There's a grade, there's a scoreboard that actually shows up. I actually happen to believe in everything that happens with Leapfrog. I think it makes us better. And so to me, it is about the systems. We have to make sure that those are fundamentally in place to perpetuate what we want to try and accomplish, which is keep every single patient that comes in our door safe.
Absolutely. I think ASC World is a little different in that we have a lot of physician ownership. And so I think that it has to start at the top, and the culture of the organization is key. And a lot of times for us, that starts with the physicians who have to be engaged, and they have to stand behind their leadership team. And like you, put the time and effort into the education with their leadership, and then that flows downhill. I think staff sees that and that they care. We offer, luckily, I work for an organization that offers a lot of leadership training, and then we turn that over to the staffs as well. We do the patient of safety culture surveys for the staff, culture of safety surveys, and I just think that is key to let our staff know that we care and we're invested in them and we care what they think, and I think that changes the organization as a whole.
So I'm glad we're talking about culture. And when we mention culture, different people have different definitions. But I want to give you the definition that I use. It comes from the great philosophers, the Temptations. It's about the way you do the things you do, the decisions you make, the resource allocation that occurs, the strategic planning that happens. And I dare say that every healthcare organization I can think of has on its walls these statements of vision and mission. But it stops on the wall. And it's got to come off the walls into the halls, into the hallways. And I can walk down the hallways and ask a question or two, and I pretty much know whether we line up with what I call our say-do ratio. We should be 1-to-1. If we say it, we need to do it. But one must also remember that accountability is a culture issue. So along with transparency comes accountability. And there is not allowed, because of one's place in the hierarchy, an exception to those rules. This is where the ethics comes in, Leah, that you brought into being. And so we have to hold people accountable because we have standards, and Leapfrog sets standards, and we need to meet those standards. And they have nothing to do with race or gender or ethnicity or generational differences or physical ability. And so what I'm finding from one who has been on that very basic level of accountability is because of fear of retaliation, which might take the forms of being fired, or if I'm a patient, I speak up and I won't get the best care next time, they won't answer quite as quickly. It paralyzes, just like that paralytic drug that Leah talked about, what people do, because they're humans too, and they need to survive. And yet, in this system that we talk about, because the thing that makes a system is that there are connections. At the very top of that overlay are the issues around equity, disparity, racism, which we don't want to talk about or deal with. And without exposing those pieces, we can't get to the root of why these disparities exist, who gets treated well, and who gets less. We need to look at the curriculums that prepare the providers, because that's where it all starts. I mentioned, I think yesterday in a meeting, where physicians are still teaching future physicians that people of color have a higher threshold of pain than those who are lighter, and therefore they need less medication.
Unbelievable.
Unbelievable in 2022. Still teaching this, and the practices occur based on those pieces. So you have to have voices at the table who will push against it, who will talk about it, who will raise it. It is one of the reasons you need diversity in practitioners, and why you need diversity at the C-suite, where the big decisions are being made and the big resources are being allocated. And it's where all of us have to use our voice to call wrong when we see wrong. And when we're not living up to the oaths and the creeds and the things on the wall that we have not lived up to. So yeah, it's all about culture. And it's all about how the systems function and dysfunction.
Thank you.
Thanks.
Michelle, as you think about answering this question, you are one of the authors of that article I mentioned that was in the New England Journal of Medicine about the need for resilience in healthcare systems. How do you do that with these systems?
You know, it's a great question because systems are obviously very challenged right now. They're challenged with workforce issues, they're challenged financially, but frankly, that doesn't give any of us a pass on not doing this. And I think what we really need to be doing is rethinking and re-engineering some of our systems around safety. I think it starts at the top, the C-suite and the board suite. They set the culture and their tone and their expectations and how they walk the talk, what's on their dashboard, frankly, what their compensation package is and what it's linked to, are all important indicators of just where patient safety and quality rank in the organization. You know, I've been in many boardrooms, and sadly, I will tell you that for the most part, patient safety is not the first priority, or the second, or the third, or the fourth. It's all about financial performance and merger and acquisition and my system's bigger than your system. What we need is a culture in American healthcare of the old Hippocratic oath, centuries old, first, do no harm. And I think that starts in the boardrooms of America and with every CEO and healthcare leader that then has to trickle down to the very front lines. But I think the front lines want to be engaged in that. Every frontline clinician, somebody who looks patients in the eyes and holds their hands and is with them when they're ill, they want to be engaged in the best care possible. And I think you're right, some of the workforce has been burned out and turned off because they don't see that commitment sometimes across their organization in the way that is meaningful for them. So I actually think this starts with culture, with leaders, with governance, with boards. You know, HHS, some of you may know this, a few weeks ago, Secretary Becerra convened the top 20 healthcare system CEOs in the country, and they were able to bring a board member and their chief quality officer and said, patient safety is urgent and it's imperative, and what can we do? And the board members, many of whom, you know, are now behind closed doors actually having an open conversation, we're like, we don't know all of this. We don't know this data. We don't want to question the clinicians because we don't have clinical experience. And yet, those boards are making decisions about resources and where they go, for example, and what the priorities are of the organizations. So I think it starts with leadership. But I do want to echo one thing that Rumeh said, and that's also our educational systems. Because my daughter is a physician. She's a pediatric intensivist. And I've watched her now through medical school, one of the top medical schools in the United States, residency, fellowship. You would all recognize the names if I told you the top programs in this country, and not one of them taught patient safety. And believe me, I watch for it. Yeah. Where is it? Where is it in our curricula? And so I think it's not just incumbent upon healthcare CEOs and their boards, but our educational system. I would agree.
Michelle, can I just add one thing? I just to comment on that. I loved every.
By the way, Virginia Mason has always been an outlier and very good in this. So congratulations for a great system.
Thank you. And I just wanted to add that, you know, again, when I came in 2015, if I looked at some of the board agendas that we had, you're absolutely correct. There was the financial report took up a lot of time.
Right.
There's some things that we did adjusted. This is before the merger happened, and we still now perpetuate it. The first topic outside of our reflection is the quality committee, patient safety, and patient experience. Those three things are talked about and has more airtime, if you will, on the board agenda than anything else. Second, historically, Virginia Mason Medical Center actually brought a patient into our boardroom. We've actually now taken that practice and are starting and doing that at our health system board, not at the hospital boards, but the health system board. And I will tell you that those two things, those two agenda items, actually have the most discussion from board members than anything else that we do. And so I would encourage anybody that's sitting here in the audience that is serving boards is to make sure you get patients in the boardrooms. There's nobody else that can tell the story.
Absolutely.
And the board members don't want to hear all the great things, just the great things. They want to hear some challenges that we've had and what we're doing about it. So thank you for that.
Completely agree with you.
It's troubling to me to hear about the wonderful things that some organizations are doing when I know so many aren't doing it. So yes, I think it starts at leadership at the top of the organizations, but it has to be a signal that comes from leadership above organizations. Yeah. I mean, why is Virginia Mason doing what it's doing? I mean, you're not part of the dignity system too, or the dignity system is part of you, I think. Dignity, as a system, embraced candor. Candor is all about open and honest disclosure to patients and families. It's also about taking care of your workforce and giving them the tools and training they need because they're traumatized when harm happens in their organization. It's also about doing real root cause analyses so we get at the embedded cultural issues that Rumeh mentioned. But we have a handful of systems in this country that have embraced it system-wide. MedStar, Dignity, a few more. So I think it has to, you know, payment, public reporting, budget, those things that give Leapfrog the tools that it needs. I mean, our grading system for hospitals comes from the private sector, really. I mean, I know CMS has one too, but the best one, honestly, is something that Leapfrog put together because it brings in more kinds of data. So there has to be that kind of leadership. And one of the reasons I'm so impressed with Michelle Schreiber, the doctor sitting next to me, is the work that she's been doing through the measurement process to really push structural metrics through the NQF process. And these have been a little controversial because they're not outcomes. We're also wedded to wanting to see what produces better outcomes, but these do go to culture. It's like, and the first one I think, because I was a fan of this, was focusing on maternal and child health care, which is another huge crisis in our country that has just been kicked down the road. I mean, we look embarrassing when we're compared to other countries. And basically, what the structural measure did is required hospital organizations to prioritize that and start doing something. You know, we were not sure exactly what you should be doing yet because the science isn't there, but you've got to be doing something at the leadership level to say this is going to be a priority. In the last year, again with Michelle's stewardship, they've really focused on health equity and the kinds of data that we need to actually measure whether we're making a progress there. We don't even have good data about the demographics of our patients coming in, much less the workforce. So all of that stuff has to start with, and the formula that I just love is build it into your strategic planning organization, get your leadership involved, gather the data, analyze the data, use the data in improvement, and have oversight. I mean, it's a pretty simple thing, but it'll get you culture change. It's the sort of things we need to do.
So here's my question. We know that there's this problem. I think you've all been quite eloquent in describing how the problem plays out, the boardrooms that don't put a priority on the discussion around patient safety, the education system isn't educating on it. Just all of the problems we know exist. How do we kickstart, how do we make it urgent? That's different from just being an issue. This is urgent when 250,000 people are dying every year. So what is that going to take? And here's in particular, of course, what I'm thinking of. What can Leapfrog do? And by Leapfrog, I'm thinking of purchasers, payers like purchasers, and others outside the health system. Is there something we should be doing more, or patients and consumers? Is there something more that we should be doing to create the urgency that's needed?
Can I
Michelle?
take that for a moment? I would encourage everyone in this room and everyone who has any relationship to this to get involved in advocacy, because honestly, that is one of the important ways for moving the system forward. That means your local congressmen, your senators, your local leaders, the people who are making bond rating decisions, even locally or nationally. Advocacy, and nobody speaks as eloquently to this, frankly, as the patient and the patient advocates, and getting engaged and involved in really creating a voice around this. The good news is, and some of you have heard this, if this plays out, this appears like it's going to become a White House agenda. And if that happens at the very top of government, because you're right, our president has been involved in healthcare. If that happens, the whole of government actually will respond, and the whole of healthcare, I think, will respond. But if it doesn't, I still think there are lots of opportunities, and this is an opportune time for everyone to get involved, to speak up, to have a voice, to lead by doing, because I think the time is right, having watched the decline in performance around safety for the past couple of years. I think everybody is ready for a change, but be an advocate and speak up. It's advocacy.
I think that's, sorry, please go ahead.
I was simply going to add to that Leapfrog's continued focus on equity and expose it, and it's intricately involved in the metrics we use to grade. It shouldn't matter if when people walk into institutions and the C-suite is not diverse. There's a message there. And so not asking who's missing from the table and how you get that difference of perspective and thought so that you make the best decisions. So there are things that I think can be infused in our metrics. It certainly is what patients pay attention to. They notice when the staff's not diverse. They notice when the leadership of organizations aren't diverse. And they're wondering, who spoke for me, who understands what I'm going through. The fact of the matter is, when experience speaks, it speaks loudly, and the visibility around these stories, which, by the way, is a form of data gathering, is just as important. Qualitative research is just as important as quantitative, and it's the combination of the two. The eloquent way you told the stories today, Leah, change people's thinking, and it hits at the core of what happens when we murder the spirit of individuals and we physically don't take care of people, or we make some gesture that says you're not as important, or you're not worthy, or you shouldn't have what other people have. That's just basic lines. So this equity focus will help, because equity is all about giving people what they need, when they need it, in the way they need it. It is not one size fits all. And that's part of the issue, is sometimes we want to standardize what we do, and that works for some, and it doesn't work for others. So how we point out those discrepancies, how we show what we do by disaggregating the data so that it shows which groups are faring well and which groups are not, or another important piece, which I know Leapfrog's been talking about. So I'd add that to the mix. And then we need to work on the workforce. And how do we get more adequate providers in this space? I'm in one of the top nursing schools in the country. We turn away 1,500 students a year. Wow. And they have 4.0s because we don't have enough faculty to teach them.
Wow.
And we're sitting in the midst of a shortage. We'd love to teach them if we had the faculty, but you know what one of the issues are? One of those issues is around what faculty are paid. I can go and make 3 times as much money working in a hospital, and I don't have to grade papers at the end of the day. Or take a project that was due at December 5th by 12 midnight, and I get it at 11:59 p.m., and then I get another email at 12:05 saying, "Did you get my paper?" So the point I am making is that there are capacity problems that don't help us educate providers so that the stress and the strain is not on the system. And I don't hear nearly enough talk about that. So that's another place where we might apply some pressure as well.
Thank you. Katul, I think you had a comment on this.
I just want to probably even tie the two comments together. It just amazes me when I meet with many of our legislative officials how much misinformation is out there in terms of their knowledge base. One of the things I also want to mention is that with Renee's comment, we've actually started a very prominent partnership with the Morehouse School of Medicine to actually train Black men and women with residencies and fellowships in the Pacific Northwest. It is one of our signature pieces that we're doing in that community, because I 100% agree with Renee that without investing your organizations in the important work around diversity, it's going to be challenging for us for another generation, which we cannot allow in our health systems moving forward. It is a big issue around our workforce, a big issue around the patients when they walk in the door. It's in my opinion, our obligation to make sure that continues and perpetuates.
Thank you. I think we're close to being out of time, but I'm gonna turn to Beth quickly. Is all this true about ambulatory surgery centers too?
I would say probably not quite as large a scale, at least in my experience. We've definitely had issues in the workforce. I have seen across the ASC community friends that I have working. Luckily, some people have wanted to come out of the hospitals, unfortunately, for the hospitals during the pandemic and come to the ASCs. And so we've done a pretty good job of holding the workforce. I would say one difference in ASCs and hospitals is we do elective procedures. And so if our staffing is compromised, we can cancel cases. At the hospital, they don't have that luxury, obviously, of taking care of an ER patient or an ICU patient. And so you do have to stand behind that, though, and not kill your staff. And you do have to, leadership has to have their limits, and we don't have enough staff, and I'm sorry, but we're gonna have to cancel cases for today. And so you don't want to do that, but you have to do that for patient safety.
Thank you. I wish we had more time, unfortunately. We ran out of time, or not for questions, right? Is that?
We've got 10 minutes.
Oh, we have time for, how much time do we have?
10 minutes.
15 minutes, okay, that's, all right, good. So if you have a question, there's folks with mics. Can you raise your hand if you have a mic? No, we don't have too many mics. Dylan has a mic. Okay, if you have a question, he'll run over to you. Or, yeah, we're not gonna go there. Okay.
Just wasn't sure. Oh, this is.
We can hear you.
Can you hear me? Yes. All right. Michael Dowling, who was recently named Modern Healthcare's most influential person of 2022, also CEO of Northwell, recently gave an interview with Becker's, and he said it was about ground rules for cost cutting. And I bring this up because I'm going to ask a question based on it. And the first rule, he says, is be extremely careful about negatively impacting direct patient care. Although nothing should be completely off the table when scrutinizing costs, this area requires careful analysis. Nothing should be off the table. And that's in a prominent publication by, again, 2022's Modern Healthcare's most influential person. How do we as purchasers, employers, policy leaders begin to get at that mentality that is at the very top of the biggest healthcare systems in America?
I'm happy to take that. First of all, I know Michael Dowling quite well, and I know that some of the comments that he's made, I'm sure, are very real to everybody. Here's my take on that question, at least the question that was asked by Scott Becker. The bigger issue that we have is in that perspective, in terms of cost cutting at the bedside, is we have to relook at the models of care that we have. And we're doing that pretty deeply within Virginia Mason Franciscan Health. And what I mean by that is there's no health system in the country that's not suffering through nursing shortages, clinical shortages, et cetera. And if we don't look at ways to find ways to do things differently, that is going to lead to a decreased level of cost, we're not going to be able to sustain in our healthcare industry. And I think that it's not a nature of just taking things and just saying we're not going to have people at the bedside. We don't have people on the bedside. I will tell you, we have the number of positions that we have open in the Pacific Northwest. It's not just at Virginia Mason Franciscan Health. It's at Swedish. It's at Multicare. Is staggering. And part of the challenges we have is we can't keep investing in those areas because we've been investing so much in travelers and otherwise. And I think that's what he was trying to say. I actually read that podcast or that series of questions this morning. I think it came out this morning.
So let me just understand what you said. So from the quote, it sounded like he was saying that there would be something that's more important than patient care. So you're saying that he didn't really mean that?
I don't think, I know Michael. I will tell you that Michael is the first one to say, and is always going to say, that we have to make sure we protect everything that we do around the bedside, because frankly, we need to invest more in the bedside to take care of the kind of patient, to have the kind of patient care issues that we're dealing with every single day. What I think he's getting at, and I can't speak for him, is that we have to make sure that the infrastructure around the staff and around some of the patient care issues is so cost efficient, and at the same time, we're finding better ways to support the bedside. And we're starting to do that more with virtual nursing. We're starting to do that a lot more with, instead of having all RNs, changing the mix of the staffing that we have at patient care. Those are the type of things I think he's implying. But I'm not answering his question. I'm saying that's the way I would answer the question if I was asked that.
Yeah, I think the answer is advocacy, or maybe even activism. I mean, getting to the people who have that kind of leverage and getting them to understand how big a problem this is what we have to do. One of the things that Michelle mentioned is this Presidential Council of PCAS, Presidential Council of Advisors on Science and Technology. It's got some of the most prominent thinkers in the world at that place, Nobel Prize winners, leaders of big corporations, and they're shocked to be hearing from the patient safety advocates. There's a patient safety work group there because they didn't think this was a real thing. So this lack of systems thinking, the lack of a systems approach to safety, I mean, that's the patient safety problem. That's the workforce problem. That's the embedded racism problem. We need to be, it's the resilience thing that Michelle's article called out. We've got to be thinking, getting our policymakers to be thinking about this in systems ways, something we've been saying to each other for the last 25 years. But it has to get out of this room. So we can all be activists. Contact your congresspeople, your senators. I mean, I'm not going to take credit for this because I don't deserve quite credit, but Barack Obama was my senator. And I live in Chicago, Illinois, and he went to Congress knowing about healthcare issues because the University of Illinois in Chicago was doing some really innovative stuff around transparency. So we helped educate him when he was local, and we can all do that, I think, with the people that we've just elected to office again. And they need to hear from us.
Okay, do we have another question? I think we have someone.
Good afternoon. Thank you, everyone. Great conversation. Actually, I have an observation and a question, and one is I'll kind of echo what Steve said. It's amazing to me that hospitals that get an F safety rating still are allowed to operate in their markets with no significant improvement over decades. So that's one. But two, I've heard a lot of conversations from all of you about, you know, the culture of health and culture of organization and systems. And I'd kind of submit to you, and kind of goes back to an old adage, you know, we get what we pay for. We're not paying for safety. We're not paying for good outcomes. We're paying for units of service. And I will, in our marketplace, we talked to a hospital CFO. This is when Leapfrog early on was promoting CPOEs. And they said point blank to us, yeah, they recognize that would reduce complications in hospital, but that would take 30% off their revenue line. So I think I would be interested in how do we attack the revenue issue? And I think the system is perfectly designed for the outcome. The outcome is hospitals and systems are looking to grow top line revenue. How do we change, how do we end up paying for getting the outcomes and safety that we want?
Who wants to take that one? Michelle?
Oh, sure.
Well, CMS is the biggest payer,
I-
so here you go.
There you go.
Obviously, I don't disagree with you, but we have a fragmented healthcare system in the United States, as we all know. And we have a system that is predicated on Wall Street and business models. You know, I think until all of us, and I do mean all of society, not just CMS, all of society, demand that this is what is important that we pay for, that's when it will happen, which is why I put advocacy or activism, as Marty puts it, at the top. Because CMS does have programs. We do pay for performance, but the amount that people can earn in bonuses or the amount that people lose in penalties is really insignificant to a lot of CFOs. You know, I've heard over and over in my career that the penalty is cheaper than the fix. And so they'll take the penalty without putting in the fix. And we allow that. And by we, I don't mean CMS. I mean we, as an American society, allow that. I've been in healthcare for many years. I've been in quality positions for many years. And I have yet to understand why safety and quality isn't first. So I can't completely address your question because I don't understand that either, except to say it's what our society values. CMS is working on it in moving towards value-based payments, in moving away from fee-for-service, in having these multiple quality value-based programs and having transparency. And you know what we hear back from healthcare? It's too burdensome. Okay? Now, look, I grant you that some of these things are burdensome, but CMS alone spends $1 trillion a year in healthcare. We really should have some good results, and we should have the right to be asking for those results. And yet that's what we hear back, it's burdensome.
If I could say one thing, what patients hear when we talk to our policymakers is, where is the American Hospital Association on this? Where is the American Medical Association on this? Those are the people that often have the ears of our Congress people. And one of the things we can do as individuals, and you can do as individual leaders, is just work through your professional associations to say, why aren't you investing in safety and quality? Why is production pressure and revenue more important than the lives that are entrusted to the members of your organizations? I think there's real room there, especially after COVID, to just get people to be looking at those issues in a fresh light.
Yeah, I think there's tremendous space right now to really be asking those questions and to really be speaking out in force around it.
I have to add something to this too. The way that we account for events, so-called in healthcare, the way that we account for outcomes is built on billing for episodes or billing for services. So we ultimately sometimes don't know, and purchasers can't even know. It's so frustrating to us at Leapfrog that it's so hard to show purchasers, here's the cost to you in human lives and suffering, as well as money for the errors and accidents and infections that affected your employees. It's very hard to account for those because it's not in claims, so it's not obvious. And it needs to be obvious, and we need to have better ways of doing it. So to be very wonkish, we need to have electronic means of collecting data on quality and safety, and we need to make all of that available. We can do much more with new systems of recording and publicizing this care. So we're really at the infancy of that. We've seen that it can have an impact, but we are at the infancy, and we have to change that because purchasers can't do anything about something they don't know exists.
Actually, if I may for a moment, because Leah knows it's one of my favorite topics, having data, having interoperable digital data that we can share and that is less burdensome, by the way, is really a key strategy. And CMS actually is working on electronic or digital quality measures that are all payer that get much more robust data than what you can get from claims because they come from the clinical information systems. And I think it's a lot of work to get there, but it's an absolutely fundamentally important journey for the United States to take in healthcare.
And I'll simply add that rather than be a bystander, be an upstander.
I like that.
Be an upstander.
Okay.
Stand up and give voice to the issues and make them visible, make them plain. Put them on billboards and any other place that you can think of that gets broad view and impact.
Upstanding. I think we have
hands up.
time for one more question.
We got 3 hands.
The gentleman in the red jacket.
Hi, I'm Dave DeBronkart, and as somebody involved in the patient side of things, I've been wondering for years, how do we get more ordinary citizens to be more savvy and just conscious of this stuff? And I had an epiphany yesterday, and in fact, your mention of the interoperable quality data just put it all together like this for me. I happened to be looking up the value of my house and my mother's house on Realtor.com, and as I scrolled through, I saw there's distance from the fire department, the nearest fire station, and the quality of the local grade schools and high schools. Is this coming in and out?
Yep,
It is.
we can hear you.
We can hear you.
Yep.
It occurred to me, why not get Leapfrog data mixed in on Realtor.com?
There you go.
That's good, Dave.
Great idea.
So you
There you go, Leah.
There's visibility.
advocacy in this work. I had dinner with a guy who had just taken a job at HHS and then decided to leave within 6 months because he discovered that he bought a house where the nearest state hospital was 30 minutes away.
Wow.
By ambulance. Why not make it something that affects real estate value?
There you go.
We will pass it along to our crack marketing team.
I
Thank
think
you.
you've got a brand new
That's
salesperson
a
for
great
Leapfrog.
idea.
I'm not new.
But we have like 1 minute left. Does anyone have a comment on the general issue too of how do we engage the public around this issue? Is there anything that we're missing at Leapfrog or elsewhere, or what is there anything that needs to happen that would engage people in this issue.
There's been a lot of work done on why people are resistant to this issue, because they're afraid. We want to believe our doctors and hospitals are safe, and we make decisions, not always ahead, but in the moment of time. So again, Leah, I think it has to be activism. I mean, I'll just put this out there too. The network that I'm part of now, the World Health Organization network, is called Patients for Patient Safety US. We're going to be hitting congressmen and senators really hard. If you want to join us, go to our website, PFPS US. Steve and Margot are part of it, Leah is part of it. You can become a World Health Organization patient safety champion, and we are aligning ourselves right now to be contacting congressmen and senators once the PCAST report comes out and we just see what President Biden's doing. So that's one thing we can do, Leah, is vote with our hands and our feet and our voices. And then we can write articles and do commentary and blog and stuff like that. But there is that resistance to talk about it. I mean, many of you, I'm sure, have had the situation I had with wanting our parents to speak up when they're patients and they don't want to get the nurse in trouble, or they don't want to, they're afraid of something that's going to happen to them. We got to get that.
Yeah.
We got to get past that. And it's our generation and younger generations, I think, that will have to do that.
Well, that's, I appreciate that. That's a concrete step we can all take, and Leapfrog has taken. We are part of the Patients for Patient Safety movement. So I want to thank my panel. I wish we had more time. This has been absolutely fascinating. You've all brought, I think, incredible passion and energy, and I think that's the most important part of the patient safety movement, is what you do every day and what you've conveyed to us, which is the importance of this. And I think if we have that kind of passion every day, we will save lives and we will change. So thank you for everything you do as leaders and for this, and for your time today for this wonderful panel. Thank you.
Thank you, Leah.
Thank you, Leah.